Good morning, everybody. It gives me great pleasure to introduce to you what we did in creating the program leading up to production of board-certified specialists in health informatics. We go a long way. In fact, we started this program working on these almost 25, 26 years ago when we set up a small committee in the Sri Lanka Medical Association. However, from that time, it's only me who is left now because everybody else, the seniors, have retired and moved away. At that time, we had these challenges in implementing what we called, medical informatics. And you would realize that these challenges remain the same even to this date. And if we were to list the 5 most challenges, these will come. These would be the 5 most challenges that we encounter. If we, some of the early work that we did is still on the web. So if you go and look at this email list that we were maintaining, the emails really highlight what we were doing at that time, 25 years ago. In 1998, we started the Health Informatics Society of Sri Lanka with the expectation of meeting these challenges. But at that time, it was difficult. In 2005, the first WHO resolution on e-health was made, but still progress was slow. And in the years that followed, we realized why we could not overcome these was because of lack of capacity and leadership within the health sector to integrate e-health into our health systems. Fortune had it that in 2007, I met up with Professor Sandeep Sahe of the University of Oslo. They were doing a lot of work in Asia, in Africa on public health informatics. And we decided together that we will initiate a program in Sri Lanka as well. I said at that time, what we really needed was to develop capacity and build leadership for e-health in Sri Lanka, not just public health informatics. So to do that, we articulated the vision. The vision that I articulated at that time was that we wanted to produce a generation of leaders in biomedical and health informatics in Sri Lanka with expertise in both the health domain and the ICT domain, who would spearhead the development of ICT in the healthcare services in Sri Lanka. I had to be very careful not to upset the administrators and the policymakers. So therefore, I said that the vision was to work with and under the guidance of administrators and decision makers at the highest level. So the generation of leaders that we were producing was going to be complementary and would support the administrators and the policymakers. That was very key to getting the buy-in at that time. So the program that we developed was developed within the University of Colombo. It was a master's program in biomedical informatics, followed by a MD program in health informatics that leads to the production of what we call board-certified specialists in health informatics. Why was this important? This was important because once you become, if a doctor comes and do this program and become a board-certified specialist, within the health services, he would have the same recognition as a consultant surgeon, a specialist surgeon, a specialist cardiologist, or whatever other specialists. So you were at the top of your field, and you will be drawing the same salaries as they were. So you have the same recognition. So if we want to create this program, that was the level at which we wanted to pitch it. So in Sri Lanka, we conduct all our postgraduate programs leading up to board certification as a specialist through the University of Colombo. We have a postgraduate institute of medicine, and in the postgraduate institute of medicine in 2008, we established what we call um, a specialty board in biomedical informatics to start this program. We were collaborating, so all of us who were part of the Health Informatics Society of Sri Lanka were providing the expertise. We had external support from the University of Oslo. Working with the University of Oslo, we tapped into some funding from NORAD through the Norwegian Center for Excellence in Higher Education. And then, so we took our proposal to the Ministry of Health. So the way we work in Sri Lanka is that the Ministry of Health releases their doctors who get through a selection exam to the program to come and train with us. So the medical officers, as well as dental surgeons who are interested, they get leave. So they get our program, the master's program was two years. So they got 2 years paid leave to come to the program, and their course fees were paid by the Ministry of Health. And at the end of the program, they become medical officers in medical informatics. They go back to the ministry, and that is the designation that they get. And then at the end of it, they can come back. They can work for 1 year with the ministry. They can come back, enter our MD program, again following a selection exam. And then at the end, then they go away. We send them abroad to give them some foreign exposure. And after getting that exposure, they come and become board certified health informatics specialists. So that is the overall program that we have. And so at the beginning, when we started the program, there was no e-health infrastructure in the country. So therefore, we had to work with the Ministry of Health to make sure that we also, bring in innovation in this program and ensure that the e-health ecosystem in the country develops through this program. So we characterize our innovation as frugal innovation. What did we mean by frugal innovation? Low cost, highly effective, scalable, sustainable innovation made on open source platforms, meeting open standards, meeting local needs. They were custom built, interoperable, and they were Ministry of Health owned and maintained. So we were within our master's program when we started doing this. So the second year of the master's program was where the students would identify a requirement in the ministry and work with the ministry to, it could be many things. It could be working on policy. It could be working on developing systems. That those systems could be on various levels, at the level of, information sharing, at the level of hospital information systems, at the level of public health information systems, and so on. So there was a kind of a ecosystem of innovation that developed. We also had this mantra. We said e-health solutions should be built by health professionals in partnership with the ICT community, and that the biomedical and health informaticians should lead the process, because e-health is a tool which should be used where appropriate, and our aim was health for the people, not e-health. It was these kind of, articulations were very necessary for us to get the buy-in for the program and get the buy-in as we went through. So the outcome of what we did by creating these graduates was not only did we create a group of people who could spearhead implementation of digital health in the country, but the framework for digital health information in Sri Lanka and the digital health ecosystem grew around this. So I'd like to show you the impact of that using the WHO ITU 7 building blocks framework. So if you look at leadership and governance, as I said, our vision was to produce this generation of leaders. So as a result of that, when we started in 2008, we really did not have that leadership established in the Ministry of Health. But by the time our first two-year program was coming to an end, in 2010 June, we established the National E-Health Steering Committee. And that committee was led by the Secretary of the Ministry of Health. And with that, the committee being established and a group of 9 of our graduates working as the resources for it, we had the National E-Health Policy, National E-Health Strategic Plan, National E-Health Standards and Guidelines, and then, of course, to promote interoperability, a personal health number, all kind of worked out and agreed on. So the documents, we started with the earliest document is what you see on the what you see there, but then several generations of documents have come into being now over the past almost 15 years. Then, of course, moving on to strategy and investment, lots of strategic plans were developed along the way. But now we are in a very good place over the years, because we now have what we call the National Digital Health Blueprint, the latest version that was launched a couple of years ago. And what it does is it also shows the roadmap for the next 10 years. And along this roadmap, the roadmap identifies the people, the processes, and the technologies that are required. And also, it is a framework on which the various funders, including the international donors and the government funding and so on, can be aligned. So that is also a very good place that we have got into. And the ministry, our graduates who are spearheading these in the Ministry of Health are taking this forward. Then, of course, services and so moving on to the services and applications. So you can see now, if you look at this, there are various levels of applications: client level, institutional level, regional level, and then the national level. And you can see here what is happening in the state sector and what is happening in the private sector. So in Sri Lanka, the state sector is dominant in the digital health space, because our graduates have gone and developed applications for at various levels, and therefore the state sector is dominant. The private sector, hospitals are lagging behind in, there are a few mobile applications for consulting doctors that are there. The electronic medical record systems in the state health sector has also grown through our graduates, and the systems that they have developed have now been deployed across the country. So there is countrywide coverage happening at various levels. And going forward, we are in a good place to scale it up and create an interoperable ecosystem covering the entire country. Moving on to standards and interoperability, our focus has also been in promoting interoperability. So from the very beginning, our graduates who've gone back to the ministry are working in the Health Information Bureau, which is actually spearheading these activities. have laid down the guidelines, the standards, adopting all the international standards, so that we are now in a position to build this interoperable ecosystem in the country and to promote communication between systems. And you can also, as I said, we've got also a personal health number, which through which we will be able to identify each client, as it were, uniquely in this ecosystem. Moving on to the infrastructure, the government of Sri Lanka has what we call a Lanka government cloud. And then we have two dominant telco operators. And they are all, have all come and are engaging our graduates in the ministry through the Health Information Bureau. And as a result of that, we have a very good relationship with them. And we are also in a good place in terms of countrywide coverage, in terms of infrastructure. Moving on to legislation, policy, and compliance, there are many, many laws that enable our digital health ecosystem. But the one our graduates have been working on very closely has been the one on the last one here, the Personal Data Protection Act, which came into operation in 2022, which was enacted by Parliament in 2022, but it will actually come into operation officially in another 2 months' time. And so we have the legislative mandate, as it were, as well. And our graduates has worked very closely to make sure that we have given the correct inputs to enable digital health with the appropriate safeguards for the patients. Then, of course, moving on to the workforce, it is just not only the it's not only the leaders that we need. So we have the consultants in health informatics, the specialists, the board certified specialists. Then we have the medical officers coming out who are not who operate at the level of the medical officer health informatics with the MSc. Then the ICT workforce within the health sector is being trained and developed by our graduates. So to support these, we have the, as we all know, the MD and the MSc programs producing the specialists, and then of course a lot of CME programs that are aimed at other categories, which are deployed through various means, the universities as well as our professional associations. This was a picture of all the graduates that we took a long time ago, actually, almost 5-6 years ago. So far, we have produced more than 300 master's graduates and 75 MDs, and a lot of them have gone on to become now board certified specialists as well. Just to highlight a few, real impacts through the services and applications, which we have been able to achieve without massive investment in software development. As I told you, we were focusing on innovation as a part of our program. So in the very early days, 2 of my graduates, students at that time, came and told me, look, Professor, we have this IMMR system, the electronic, the non-electronic version of that. So the innovation is the IMMR system. They came and said, look, we have this document called the Annual Health Bulletin, which we make all the policy decisions in the country. But in 2009, the document that we had was for 2003. And all the data coming for this was coming through a manual system called the Indo Morbidity and Mortality Reporting System. the two graduates said, the two students at that time said, yes, we can make the electronic version of it. And they went on to produce the EIMMR system. And with that, over the years, this is a timeline of how the system, which began as a MST project, developed. 2 years down the line, we had the system being deployed in the country, then getting accepted, and then being taken on by the ministry and scaled up across the country. So in 2012, it was accepted and scaled up. And today, we have all the record system, what was there as a manual system is now completely digitized. So all the hospitals in the country are reporting. And we have a situation where we have our hospitals administrators being able to access policy-making, decision-making data on dashboard. So we went in 2010 from record rooms like this to 2018 into dashboards. And this is data from the system. We have more than, now more than 60 million records of all, admissions, indoor admissions to hospitals, coverage virtually. This is about data about a year old, but we are now reaching almost 100% coverage. And we really have now countrywide data at the top of, on dashboards. So we look at disease trends. We can look at, also mortality. We can look at hospital utilization and so on. So the investment for this on this project at the beginning was only $500 as a student project. Now it has been scaled up, of course, with proper investment later on. But that is what frugal innovation within a program like this can take. So this project was actually spearheaded by one of our students who is here, Nadish Karyavasam and Buddhika Dayaratna. Nadish has now migrated to another country, but Buddhika, from the time of the student, is still spearheading it, and he has ensured that we have countrywide data for policy making, decision making at the tip of a finger, as it were. So you can imagine the impact that it has. That kind of data set also promotes research and all kinds of research, enabling you to look at the burden of disease in the country. I highlight this particular paper because, who would imagine that you can get data countrywide on a rare disorder like skeletal dysplasia in a country like ours. So establishment of a system like this enables you to access even rare disease data across the country because the data is systematically captured and coded using ICD-10 and so on. Moving on to another example of frugal innovation, the district nutrition monitoring system. Again, now this was in about 10 years ago, we wanted to have a national program on monitoring children with nutrition deficiencies. And as a part of MSc project of one of our students, we took on developing this district nutrition monitoring system. So what we had was a simple app which was used in the field by the midwives. We built on a DHIS2 backbone where the data was, reaching the Ministry of Health at different level. So the midwife would go into the community and collect the data, and that data would be immediately fed into the system, and we would have children, malnourished children, being followed up. So we had the smartphone app, which the midwives were using very easily. This was also customized to local languages. so that the midwife can use it without difficulty. And then we had the program managers looking at the data from their in the comfort of their office, as it were, being able to identify what was going on in the community, not only at statistic level, but also with GIS integration. We were able to say, in a rural village down a particular road, which house is actually having issues, where are the problems, and they were coded so that you knew what the issue at the house was. Was it poverty? Was it some other issue that was, and so on. And this innovation, which we deployed, eventually end up winning the World Summit Award in 2016. As you know, the World Summit Award is the highest award for innovation, and it won the first prize out of submissions from 178 countries. That was a frugal innovation. Again, we only spent about $2,000 on the entire software development at that time, which was scaled up. Moving on to another system, the last one that I would like to highlight here, we have again our entire child and maternal program is followed up through one directorate in the Ministry of Health. And again, one of our graduates developed this ERHIMS system and worked. So here he is. He initiated this project. It went through several phases. In the interest of time, I'm not going to go through phases. And eventually, what we have at the end is a countrywide system that collects all the maternal and child health data. So at any one given time, we have 400,000 pregnant women, all the pregnant women in the country followed up through the system, more than 1.5 million under 5 children followed up through the system, and the entire cohort of children in school, 4 million being followed up through the system. The data generated is a massive data set, nearly 100 records of data, being transactioned through this system per day. And it's a countrywide deployed system now. And over the years, we had 14 master's projects, which were, helping us develop different blocks of these system. And this is kind of frugal innovation at country level. So these are some examples of what the impact that that our graduates have had. And it is because we produce these graduates that we can talk of these things. And as you can see, the entire ecosystem had developed around the, we can talk about what was done around the WHO ITU 7 building blocks, because our graduates are working on all of these areas. Very briefly, it's just not only local impact, but they have had global impact as well, working with the Commonwealth Digital Health Initiative. So in 2013, we got the backing of the government to work with the Commonwealth, and we got the Commonwealth Digital Health Initiative off the ground. And as a result of that, we in 2016, and we had a Colombo Declaration when that backed us, and we had this backing of the Commonwealth Secretariat, and we had a policy brief on digital systems for One Health, which was approved by the Commonwealth Health Ministers also. And to support that, we established the Commonwealth Center for Digital Health, which was manned by our graduates who were working both locally and internationally. And we had a center in University of Southampton in UK, and of course, our center in Colombo. And these were the first set of fellows who worked with us. And through them, we've been working on global advocacy, going every year to Geneva, on the sidelines of the Commonwealth Health Ministers meeting and the World Health Assembly, having advocacy events. And then some of you who are on this webinar would remember the Digital Health Week that we had in 2018 here, bringing on all the global partners to work with us. And then we supported the adoption of the WHO's resolution on digital health. And as COVID was striking, we worked very closely with the Commonwealth, all the different health professionals groups to again come up with a policy brief that was taken to the health ministers, accepted by the health ministers, and adopted. And then with that entire work stream on digital health, starting in the Commonwealth Secretariat today, leading to what we call a technical country support program on enhancing digital health maturity, which has also been backed by the ministers, and we are now deploying it and supporting various countries. This was one in Zambia and Seychelles. And then last year, we showcased it in Geneva during the World Health Assembly time. And our fellows who work at Southampton have also been working on setting up this platform for Planet, Place, and People, which has now grown to its next version, where we call it the Platform for Planet, People, and Peace, where we showcase the digital solutions that can help us overcome the challenges of the environment, as well as the other global challenges that we are facing. So, ladies and gentlemen, I've very briefly taken you through a 25-year journey, as it were, but why we are in this position today is because we were able to take in doctors, train them, send them back to the Ministry of Health, get them back again, given them higher level training, send them abroad, got them foreign exposure, and brought them back, so that now they are board certified health informatics specialists, spearheading the development of ICT in the health sector in Sri Lanka, and truly living up to the vision that we had at the very beginning, the vision that I showed you, the vision of creating a set of leaders who can truly work with the administrators and the decision makers at the highest level to ensure that digital health becomes a reality. And we have local capacity at every level to ensure that we are able to deploy digital health successfully in the country. So that is the message that I have for all of you. The impact that they have created, we have documented previously. You may like to read these papers. And we are in this place because of all these graduates that we produced over the years. And I hope that as we go forward, the other countries will also be able to create their own board certified specialists who can spearhead the development of digital health, deployment of digital health, the digital health ecosystem in their countries. And so with that, I will stop, and I would put before you a kind of next steps that can form the part of the discussion that we can have in the next few minutes. Thank you very much. Over to the MC.
Thank you, Professor Vajira. Before we open the floor for questions, we would like to call on our reactors for their insights. So joining us today are Professor Ricardo Quintos II, Assistant Associate Dean for Research at the University of the Philippines College of Medicine, and Dr. Isip-Tan, Chief of the UP Medical Informatics Unit and Director of the UP Manila Interactive Learning Center. So maybe we can hear from Professor Ricky first, and then Dr. Iris.
Well, thank you very much, Professor and Dean Vajira Dissanayake. for this very interesting talk. And good afternoon to all our colleagues and participants in this webinar. My name is Dr. Ricardo Quintos, and I am the representative of the Dean of the College of Medicine, speaking to you and reacting to the lecture previously presented. It is an honor to be here and to take part in this webinar today. And I'd like to begin by offering my sincere congratulations to our distinguished speaker, Professor and Dean Vajira Dissanayake, for delivering this thought-provoking and comprehensive lecture, sharing the conceptual pearls, and maybe not just conceptual pearls, but really conceptual diamonds on his and their experience in moving forward with health informatics and producing board-certified specialists. As we all know, the field is growing at a very, very accelerated rate, both globally and within our respective healthcare systems. And the integration of technology with healthcare has already proven itself to be a game changer, whether it's in improving workflow efficiencies, providing a platform for data-driven decision-making, and eventually enhancing the final objective really is to enhance patient outcomes and delivery of service. So the early important step of developing a critical mass of specialists having formalized structured training and credentialing in this domain cannot be overemphasized and overstated. And it has been shown in this very interesting lecture by Professor Vajira of how they were able to successfully implement and drive the continued development in their country. As I was listening with growing excitement during the presentation, what I found particularly inspiring about the experience was the creativity, the resilience, and the strategic foresight demonstrated by building such a framework from the ground up from 35 years ago or 25 years ago in a country like ours, where there may be so much other necessities competing for limited resources and an overburdened healthcare infrastructure. The Sri Lanka's pioneering work in frugal innovation, I like that term so much, establishing the framework for use and developing a program for the capacity building and enhancing human resource in medical informatics exemplifies incredible potential for transformative change that can emerge from context-specific, locally driven efforts. This is not only a significant achievement for their country, but also a vital contribution and model to the global efforts, to us all, in formalizing this emerging field in a way that ensures quality, consistency, and professional growth. Let me just bring to fore some of the highlights that I took notes of in the process, as explained, as shown by the Dean. He highlighted the key steps involved in the process: curriculum development, stakeholder engagement, overcoming regulatory hurdles, aligning the program with national health objectives, and importantly, and finally, human resource absorbance, where the graduates are not only left on their own to find work after they graduate or after they're trained, but are given pathways in the ministry where they may further develop professionally. And I have an analogy to this. My other hat, in my clinical hat, is as a vascular surgeon. And for us to treat the vascular arterial obstructions, we do a lot of vascular reconstructions like bypasses, angioplasties, and stenting. But the success of our procedure is dependent on the outflow that the blood will go through after the doing the intervention. And the analogy is so the same to here. You produce the graduates, and you have to provide also the context of where they can practice it and where they can continue to develop, and then you just not produce them and let them out in the world and to forage for themselves. So this insight is invaluable, and especially for us here in the Philippines and for other nations looking to replicate the success that we've had and to leapfrog. It should not take us the same amount of time to develop it to this level. We leapfrog to current quality standards in our own context. This is exactly the type of forward-thinking approach that will enable countries to ensure that their healthcare systems are both technologically advanced and staffed by highly trained professionals capable of leveraging those technologies for the benefit of their own settings and their own populations. Okay, let me just check on my notes here. Now that as we reflect on Sri Lanka's experience, it is worth considering how other regions and countries around the world have approached the creation of medical informatics specialty and the development of the certification process. Here in Southeast Asia, particularly within the ASEAN framework, countries like Singapore, Malaysia, and Thailand have recognized the importance of formalizing the specialty of medical informatics through their respective national councils or boards, but these boards, a pathway has been opened that these boards, national boards, collaborate closely with the practitioners, medical universities, and professional organizations across countries, ensuring that the specialty training programs are both comprehensive and in line with the international standards. The ASEAN region has since developed various collaborative frameworks to standardize certification across member states, ensuring that the specialists can move freely within the region while maintaining consistent quality. The buzzword here is the ASEAN integration of specialists. This is quite similar to the context we all know here in this field of the context of interoperability applied not just to systems and software, but to the practitioners of the specialty themselves, allowing for a seamless integration of practice anywhere within the region of the ASEAN. Lastly, I'd like to turn our attention to the Philippine context, and I feel that more of this will be discussed by the next reactor, Dr. Iris. For the Philippines, we have developed a robust framework for creating new medical specialties, including medical informatics and establishing board certification through the Professional Regulatory Commission, or our PRC. The process begins with a proposal for a new specialty, and may I just share, with your indulgence, I'd like to share a photo or a document for this. And here, the document shows that this guideline promulgated by the Philippine Professional Regulatory Commission shows the guidelines on accreditations of specialty society organizations and other specialty categories, including medical informatics, for structured training programs for professionals. And this guideline, they have here all the process, all the steps, all the documentary requirements, including a level advancement matrix. No? There are certain competencies for certain levels for specific specialties that are at par with international standards, so that they can have comparable and standardized competencies across the board, just ensuring the interoperability and the standardization of qualifications, and not only qualifications, but competencies internationally, at least within the ASEAN region. So I joined the local producers of graduates here in the Philippines to get a hold of this document, and when preparing and establishing your program, to make sure it is well aligned with the Professional Regulatory Commission's drive not to standardize the competencies across the board, so that we emphasize the need for a multi-stakeholder approach involving government, academia, and industry players, as was demonstrated by the Sri Lankan experience, to ensure that the country's medical professionals are equipped with the necessary skills and to drive innovation in healthcare technology. Lastly, I would like to say that what Sri Lanka has achieved in medical informatics is not an isolated effort. It's part, I think, of a broader global movement towards the formalization of emerging medical specialties, and Sri Lanka has shown us a very feasible way of how to achieve it. So the work underway in Sri Lanka, coupled with the insights from the ASEAN, Australia, Europe, US, and even China experience, can help set the stage for a future where medical informatics is a recognized standardized specialty worldwide, improving through better data, better systems, and better patient care. So once again, thank you for our speaker, Professor and Dean Vajira, for your outstanding presentation and for sharing such an insightful and inspiring experience. We look forward to seeing the continued success of Sri Lanka's efforts and their broader impact on the global health community, and we express our appreciation for the inspiration your talk has ignited within and among our ranks. And we pray you won't mind our taking pages from your book to apply in our own settings. Thank you very much.
So good afternoon, everyone. Thank you, Professor Vajira, for your presentation. Thank you for sharing your experience, and congratulations for making such a significant impact in health informatics, not only in Sri Lanka, but also globally. Your journey is very inspiring indeed. I can also see that we share the same 5 challenges that you mentioned early in your presentation. First, for infrastructure, we have slow and expensive Wi-Fi locally, but there are certainly digital health initiatives on electronic medical records, mobile health, health information systems in primary care, and telehealth with the Philippine Department of Health, despite the challenge. And so, like Dr. Quintos, I also love the concept of frugal innovation. I think that those 2 words will be my take-home points for today. In fact, one of my most cited research work is actually on the use of short messaging services for diabetes care. And I remember at the time, people were asking me, why not a mobile app? But that was actually a good project. I would classify as under being frugal innovation. For the data challenge, locally, I would say that there might be 2 driving forces in play. First, of course, we have the Universal Healthcare Law, which mandates health information systems, including electronic health records. And the other is the current hype and interest in artificial intelligence. There can be no machine learning without data sets, and hopefully that will also catalyze efforts to have more open data sets in health, which can in turn increase the implementation of electronic health records, because that's where the data is going to come from, and ultimately move forward to interoperability, which, as we know, is the holy grail in health informatics. We do have an Open Data Philippines portal, which shows that there are only about 175 data sets currently in the registry. And when I looked at the health registry, there are only about, very few COVID data sets from 2022. The third challenge you mentioned is data security and legal issues. We do not have an e-health specific legislation for the Philippines, so there have been multiple attempts in the past to have law passed. But we do have the Universal Healthcare Law, which has an entire section devoted to health information systems, and it actually mandates a national health data repository. The Philippines also has a stringent Data Privacy Act, though we do not have health-specific legislation like, for example, the HIPAA for the US. We also do not have enduring telemedicine legislation, though during the pandemic, there were Department of Health memorandum orders to allow telemedicine, and the Philippine Food and Drug Administration also allowed e-prescriptions and issued guidelines governing its use. The last challenge is finances and sustainability, and I can only say that this will depend on the priorities of our national government in allocating budget. Now, currently, the University of the Philippines, Manila offers a Master of Science in Health Informatics program, and we have 2 tracks. We have a track on medical informatics, and we have a bioinformatics track. The program was actually approved in 2004 and began accepting patients in 2005 when I enrolled. I was the first graduate in the medical informatics track, and Professor Alvin Marcelo was my mentor. So the program is jointly offered by the Medical Informatics unit of the College of Medicine, and then the College of Arts and Sciences, because that houses the Department of Physical Sciences and Mathematics, which also offers an undergraduate degree in computer science. So the College of Arts and Sciences handles the bioinformatics track. For the Philippines, there is no board certification for health informatics. So we're really grateful to listen to your presentation today and see how we can move this forward. If this will be the pathway, it will be likely through the Philippine Society for Digital Health, formerly the Philippine Medical Informatics Society, because through the efforts of Dr. Marcelo, it is an affiliate organization already of the APAMI and the IMEA. So currently, the University of the Philippines College of Medicine also offers an MD PhD program and an MD Masters of Public Health program. And prior to this, we have been mulling the idea of actually having an MD Master of Science in Health Informatics joint program as well. This webinar is perhaps a nudge from the universe or from Dr. Alvin Marcelo. But we have a revision also for the master's program pending approval. And the most major revision in the program is actually to accept individuals without any medical or paramedical background. Currently, the medical informatics track only accepts physicians and other paramedical degrees. So currently in the program, I have physicians and I have specialists and subspecialists. We have cardiologists, pediatricians, rheumatologists, also general practitioners, but we also have nurses, pharmacists, nutritionists, physical therapists, radiation technologists. But by opening up the program to those with no medical background, we want to actually bring in more diverse backgrounds. We're also thinking of having stackable micro certificates, earning the units towards a master's degree. In fact, prior to the current revision, we were planning to offer certificates in health informatics because our program, actually, the students have difficulty in completing their dissertation or their thesis. So we were thinking of having instead a certificate program where they only have to do a capstone. However, the University of the Philippines has a very strong research mandate, and as such, it supports master's programs. And we were just told to reduce the number of units so that we can have more easier access for our graduates. Now, in the current revision, we are also thinking of offering tracks within the Master of Science Health Informatics by having tracks in translational informatics, clinical informatics, and public health informatics. So we are waiting for the approval. Now, in terms of the Philippines, the Chancellor of the University of the Philippines, Manila, has a seat on the Philippine National E-Health Committee, and various faculty of the UP Manila are also in the technical working groups. And so for the Philippine National E-Health Strategy, the UP Manila has been identified as a Department of Health's partner in capacity building. And I'm sure they will be very excited when we start talking about having board certification. Moving forward, there is, as I said, much interest in AI that I've been having to caution educators that education in AI should not be approached in isolation and piecemeal, but rather as part of a broader education in health informatics. So for me, I think this interest in AI is an opportunity. AI can be the hook to rolling out more initiatives in health informatics in more shapes and forms, and certainly working on having board certification. So I learned a lot from you today, Professor Vajira. Thank you very much.
Yes, thank you, Dr. Iris and Professor Ricky. I think we have a question from Dr. Bunchay. So it reads, how do you work with SL Medical Council to certify DH specialist?
Okay, so maybe I should show my last slide that I was sharing earlier. Can I then clarify it? So because I think it'll be relevant to everybody on how they can go forward. So when you are, developing a program like this, I think it's important to look at the regulations and laws in a country, which and how they certify doctors as specialists, because the programs, are different in different countries. Then you also have to examine how the training is conducted and governed. So certification is one thing, but how you train people and how you, manage that training process is also important. Then, of course, you have to also have an understanding of how you establish links with institutions that are responsible for initiating the process. Who gives approval for you to start? Is it the ministry? Is it the regulators? What about the training? How are the universities involved? And how certifying? How are the boards involved? And then, of course, working with the employers to, create cadre positions for these people, and then also defining the job description and so on. So to answer the question that was asked from me, if you look at this process that I showed you earlier, once you become a board certified health informatics specialist, so there is what we call a specialty board in the University of Colombo that will give the board certification. It'll say, okay, the board also, basically monitors this entire program, as well as once somebody has completed the process, evaluates the person and gives the board certification. So that happens at the level of the university. The Sri Lanka Medical Council is not shown here. The council recognizes the board certification that is given by the university and then registers them as board certified consultants. So they give the specialist registration for them to operate as board certified consultants. So that is how the council comes into play and gives the board certification. Okay, so that's how it happens. What I wanted to also little highlight here is that today now we also have the Sri Lanka College of Health Informatics. So our specialists who've produced have now gone on and formed the Sri Lanka College of Health Informatics. So they are now taking over the administration of the board and the entire governance process. So we have gone the full cycle, as it were. Like people like myself, we were kind of part-timers who had an interest in, IT and applying it in the IT sector. We had, other qualifications in IT, not, digital health qualifications or health informatics qualifications. As you know, those programs came into being later on, and we were the ones who developed it. But now the trainees that we took through those programs have now coming, we are getting them to the forefront. They have formed their own professional college, and we are now bringing them into the university so that they can deliver the programs, administer the programs, and govern the entire process. So that is what we have done. So again, going back to this slide, so working with the Sri Lanka system, so understanding the laws and regulations in the country on how you provide, certify somebody as a specialist is important. Then looking at training, conducting the training program and governing that process is also important. And then establishing the links with the ministries of health, the other regulators is important. Then training the university is important. And of course, the boards that are involved in that process. And then, of course, the long-term sustainability always depends on whether the graduates that we produce have a place of work. So working with the Ministry of Health, working with the private sector, ensuring that there are positions, cadre, identified designated cadre positions are there. There are defined job descriptions are there. It's all very important. So it is, so we, as you have seen, we went beyond just delivering a master's and an MD program. We made sure that our program is relevant to the ministries of health. It supported their ecosystem development. It supported creation of job positions. It supported the description of the job descriptions. And then also we work with the regulators, ensuring that once somebody is board certified, that they got the regulatory approval, the Sri Lanka Medical Council and so on. They gave the regulatory approval to certify them and ensure that they are able to practice. So working with this entire ecosystem is so very important. I hope that answered the question.
Thank you, Professor Vajira. You've had the head start of over 14 years, and we are happy that you have showed us the way. I think what we want to happen is to learn more from how we can also do the same thing in our country, given our own local constraints and regulatory mechanisms. But I think if we can approach this also from a network perspective, like informing our local regulators that this is happening also in other countries, and we can show the Sri Lankan example. I think that's going to be very, very helpful. We have a lot of universities in the call.
I think one of the things that we could potentially do is, Alvin, at a next AHIN meeting, have a kind of side meeting with different countries on, what their, ecosystem is, and then have a discussion on how maybe, give everybody ideas on how they can really go forward in each country. Because as you know, like, I think, as you know, like in our countries, the doctors take the leadership. So therefore, like having, board certified consultants who can take that lead. Dr. Bonchai.
Thank you very much, Dr. Vajira. I think Cha forgot one question that I posed earlier. My question is that, the government changed several times and many frequently, especially Sri Lanka. We know that one of the countries that have a lot of change. Could you give us the secret sauce that how you as an individual or something like that work to navigate through this to get through all 25 years of this effort? Over to you, Dr. Vajira.
Okay. Yeah. No, I think, well, we are working at, so I think, the specialist training programs and others don't change with government change. They remain, so they are within our control. So there is no, no impact of government change on the way we produce specialists. And also, again, for us, the professionals in Sri Lanka, we don't have any impact on government change, as it were. Sometimes policies change, but by and large, the by and large, the direction in the health sector remains under a strategic, 10-year program. So although the government change, those programs continue, and therefore we generally have had no issues of government change. It is the only thing, maybe sometimes you have to engage the Minister of Health and explain to them what we are doing, but generally the direction has been, the same. We have not had, reversal of decisions as such. So,
as you said, this is just to get more insight from you. And you say that it's not just the training program, and it's not just the other, but it's also the demand of the market and how we are going to create the demand of the market. But most of us in lower middle income country, the demand for the I mean, the physician to get this kind of the specialist is all most of them are in public space, a little bit in the private space. But if the government change, they are not provide the position or this kind of the way, the direction. They have more another kind of the priority. And how we going to convince that other than the plan, the project for 10 years? But to me, I think the power, when power shift, it a lot in terms of the demand side. I have recently the experience that the new young doctor come to me that what is my career letters? I don't know how to answer him that this is 1, 2, 3, 4, 5, but you are very success that you can get the Ministry of Health to put the job, the digital health or e-health specialist job inside the work ecosystem in Sri Lanka. What is the secret that we can follow your lead over?
Thank you. I'm not sure whether I understood exactly everything the way you wanted to, but you know, I think what we found is several things. I can tell you there are lots of you know, doctors who come into the field who want to do other things than just practice medicine. So therefore, like our program actually has given them that opportunity. There are a lot of computer savvy doctors, as it were, who come in, and then that given them the opportunity. And I can tell you, so becoming a board certified consultant doesn't prevent you from practicing as a doctor. So therefore, some of our graduates continue to practice as doctors while they are they work in their specialized field as well. So they do that. So they have the best of both worlds, and we in a way encourage them not to give up their you know, clinical practice also, because then they have a touch of the field. Yes, I agree with you. Like the development happens mainly within the, you know, the government health sector rather than in the private sector. And my challenge at the moment, I think, is our graduates are sought after around the world. So therefore, like keeping them in Sri Lanka is my challenge. And they work as consultants for WHO and other international organizations, and you know, they are sought after everywhere. So so keeping them in the country and supporting them. So but what I encourage them is to, wherever they are, like even if they were to, you know, go abroad, to contribute to the country, and they can contribute in so many ways. So so I hope I answered you know,
Thank you.
your question.
Thank you, Professor Vajira. We've reached the top of the hour, so I'd like to thank everyone. Dr. Iris already went to her AI workshop. Dr. Quintos, thank you very much. And thank you, Professor Vajira. Group photo, please. And while we are posing for our picture, I'd like to invite everyone. We will put this program that was suggested by Professor Vajira into the next AGM. We will try to strengthen the university subgroup inside AHIN. Dr. Vajira, we've been ignoring that, but actually we're all in the academe, and we can actually work together and follow the trailblaze that has been shown by the Sri Lankans. Thank you, everyone. Thank you,
Thank
Professor
you.
Vajira.
Bye. Thank you.
See you
Thank you,
soon,
Dr.
Dr.
Vajira.
Buchay.